Hello, everyone. Welcome. We have someone special here to give our grand rounds. Mick Oreskovich, whom I worked with when he was a resident at the University of Washington program, and he spent his time at Harborview. He is a board-certified general and addiction psychiatrist, general and trauma surgeon, and former medical director and chief executive officer of the Washington Physicians Health Program. He is a clinical professor of psychiatry at the University of Washington and a fellow in the American College of Surgeons. He completed a VA MIRECC research fellowship in opioid dependence detoxification. He has published 40 articles and 4 book chapters as a surgeon and as a psychiatrist. Mick currently serves as a psychiatric consultant to the American College of Surgeons, Board of Governors, Committee on Surgeon Competency and Health. He is one of the co-founders of Psychiatric Medicine Associates, and he's going to speak with us today. Mick.
Sharon, I thought what I gave you was a little bit longer than that. But
You've done so well with your sinus problem. I'm proud of that.
and I really like that word special. Well, good afternoon, everyone, and thank you so much for coming here. And it's always very special for me to come back to Harborview. I actually have a 40-year relationship with Harborview. I rotated here in emergency medicine as a medical student in 1973. Met Dr. Kopis, who I had as a friend for 40 years. Did my surgical residency here, was the chief resident in surgery in 79 and the chief resident in psychiatry in 2001, 2002. So that's a little bit unusual. Was on the faculty, was the chief of trauma surgery and the director of the regional trauma center in 83 and 84. And then came back in 99 to the best kept secret, which is psychiatry, and did my residency and the 2 fellowships. So Harborview to me is the mother lode. It's a very special, special place. And I was walking around for a few minutes before I came in here and had some wonderful nostalgic memories. So I'm really delighted to be here. The reason I put trauma surgeon and general psychiatrist, addiction psychiatrist, is to qualify as an expert on stress and burnout, and as a trauma surgeon, and hopefully health and well-being, professional and personal balance as a psychiatrist. And I'm going to take you through a series of studies that we have done with the American College of Surgeons and the American Medical Association in this regard. Specifically talking about the relationship with burnout, depression, suicidal ideation, substance abuse, and medical errors. And I want to say at the outset, the leadership of the ACS, the current president of the ACS is Carlos Pellegrini, who's the chairman of the Department of Surgery here, has been tremendously supportive about finding out the truth. What is the actual point prevalence of these disorders? What is the chance of recovery from these disorders? And how does it relate to patient safety? So it's been a fairly hot button topic for quite a while. So the landscape is changing. It's rapidly changing. I have to read the front page of the New York Times every morning to find out what's really going on in healthcare. And it's rare that there's an article that doesn't portend trouble in the future, I guess is a fair way to say it. And we're seeing this increasingly in the various publications that are coming out. For example, in physician suicide, we know that male physicians complete suicide at twice the rate of their professional counterparts in the general population. And female physicians commit suicide twice as often as male physicians commit suicide. And that is the only gender shift in suicide in any reported series. We do know that women have more attempts and are less successful, but the fact that a female physician has a 4-fold higher chance of committing suicide than a female lawyer or accountant or engineer is really quite provocative. So, the biggest crisis in U.S. medicine, we hear this all the time, we read about it, we learn more about it, and I would like to share with you a bit of a different perspective in that regard. Is it managed care? Is it where, cost trumps quality, where parameters for treatment are dictated by the dollar? I would submit to you, well, that's hugely problematic. It's not the biggest issue. What about the need for tort reform with still awards in the tens and $20 million? Is that the most pressing component of the crisis? What about physician shortage? Within the next 15 years, we will have a gross shortage of practicing physicians. To meet the needs of my group, I'm 65, it's going to cost $12 to $15 trillion to take care of my group until we die, and we're short between 22,000 and 30,000 physicians to do so. Is it healthcare reform and the ACA? And you probably saw today that the president has pulled back on one of the requirements of the ACA. I would say in Washington State it's quite remarkable how well it's working, however. But I would submit to you that the biggest concern is the health and well-being of physicians. And I'm going to share with you various data which I think is quite substantive and supports that statement. We have a terrible time giving ourselves permission to be sick. And in general, the quality of care that we receive is substandard to the patients that we provide care for. Of surgeons who have depression, a quarter of them, if they're taking an antidepressant, have self-prescribed or have gotten a prescription from their fellow surgeon. Just, I think, a compelling example of really poor care. We all know the old saying, the physician that treats himself as a fool for a patient and a charlatan for their doctor. So what do we know from our studies? And I'm going to share with you three study sets from what we've done with American College of Surgeons, and then the last 2 years we've had access to the master file of the AMA and have conducted a number of studies looking at specialties and their risk. Well, we know that burnout is a huge problem. I would submit to you that at this point in time, in this room, probably a third of you meet Maslow's diagnostic criteria for burnout. At this point in time, practicing surgeons in the United States, 40% of them meet diagnostic criteria for burnout. 6% of them endorse suicidal ideation in the past year. Roughly 25% meet diagnostic criteria for depression, and about 15% are abusing substances. Burnout is a huge problem, as are these other entities. And this is what we have found to be true. There is a statistically significant association of burnout with depression, with suicidal ideation, with substance use disorders, and with medical errors. And again, that the college allowed us to do this kind of work to determine this is just an amazing example, I think, of leadership. But burnout is completely reversible. We suffer it, we experience it, we incorporate a number of different interventions, and we're able to reverse the state of burnout. We now have a 7-item well-being index on the Mayo Clinic survey site where people can log in, take the well-being index, get feedback as to whether or not they have burnout, depression, etc. And these online self-assessment tools, I think, are the future. So this is the first study, Charles Balch and Julie Freischlag and Tate Schoenfeld. And let me, at the get-go, mention that Aladi Derby and Tate Schoenfeld from the Mayo Clinic are clearly the world's experts on physician health and well-being. And they, in fact, train here in internal medicine. And the Mayo Clinic Survey Center is the center that we use to conduct these surveys, which is probably the most experienced survey center in matters of patient and physician health and well-being in the world. And when we do these surveys, we're presented with a data set, with tables, with a statistical analysis that's already been done. It makes it pretty easy to write papers. And so I have to say that those two colleagues of mine have been absolutely remarkable. Anyway, the point is using the 3 Maslow criteria instead of the 22, depersonalization, emotional exhaustion, and low personal accomplishment, which have been vetted and validated to be as effective as the Maslow 22, 40% of surgeons meet diagnostic criteria for burnout. If you think of that from a standpoint of quality of care, longevity, sustainability, this is a huge, huge issue. And in contrast to you and I that are much more sensitized to issues of feelings and empathy and sympathy in relationship to patients, surgeons really struggle a lot with this. Because I was taught during my residency, that if it isn't working, try harder. And if that doesn't work, you need to work even harder. Now, I want to use Kearney. Kearney writes extensively about physicians that are hospice-based that have a very high incidence of burnout. The overwhelming physical and emotional exhaustion. So when I pull up, I usually get home about 7:15, into my driveway, I start hearing this thump, 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 thump from my house. And it's my dog who's throwing his little body against the French doors, so excited to see me, he's heard my car. And when I turn the corner and I see him jumping up and down, I get such a positive emotional response that trumps anything I've been feeling up until that moment. People that are burned out don't have those kinds of experiences. Totally tapped out, totally emotionally and physically exhausted, can't even generate anger. Feelings of cynicism and detachment from the job. Instead of the 67-year-old father of 3, when their kids are top of their class in Harvard, and this is what they do in their life, they're the gallbladder in 6 East, which has to be added to the schedule today, which is going to be a big pain. And we lose that empathic connection to our patients. Our patients become annoying, inconvenient, non-compliant. The definition of a good patient is one who is easily diagnosable, easily treatable, and is very grateful and tells us we're the best doctor in the world. We love those patients. The ones that don't say that to us are difficult, and in the face of burnout, we'll have tremendous cynicism and detachment about what we're doing. And the third criteria, as I mentioned, is a sense of ineffectiveness and lack of accomplishment. If you really knew me, you would know that I'm actually not a very good doctor. I've kind of been faking it till I make it. And that sense of loss of self-esteem and ineffectiveness and lack of accomplishment to a healthcare provider is a huge, huge red flag. Well, Kearney talks about some other things, the over-identification with our job. With respect to substance use disorders in healthcare practitioners, specifically physicians, the last place for the disease to make itself present is in the hospital, in the clinic, in the department. That's the last thing to go. Our marriages can be falling apart. Our kids aren't talking to us. Our family is estranged from us, but we're still showing up for work. And the tremendous over-identification of not who we are, of what we do. Irritability, hypervigilance, another symptom. Sleeping problems, including nightmares. Social withdrawal. The person who's kind of missing in action doesn't make eye contact. And when we make eye contact, we get a warm response. We get a little squirt of serotonin. When we're not making eye contact, it's usually because we have a secret. This is the person who's kind of missing in action there, not there. A burnout is a great predictor of professional and personal boundary violations. Writing a script for Xanax for our next door neighbor because they're leaving on the 8 o'clock BA flight to London. And getting in this pattern of getting kind of sloppy and entitled with respect to personal professional boundary violations, leading eventually to poor judgment, always complicated by perfectionism and rigidity. Glenn Gabbard says perfectionism is a physician's personal toxin. And if you haven't, I would strongly, strongly endorse reading the book, The Physician as Patient, by Gabbard and Mike Myers. You will read about yourself. You will read about your perfectionism. And this room is full of perfect children. Perfect children become doctors. And finally, questioning the meaning of life, silently screaming. So what I want to share with you is that it appears that this high association of a completely reversible, treatable disorder with other more life-threatening and patient-threatening disorders is really quite compelling. So last year, we published this paper, and this was the first really controlled study in the sense that we had a control group. We had a data set of other professionals that had been followed for long periods of time, and we knew what their incidence of burnout and depression was, and we could compare it to the data set that we was generating. And we wanted to replicate the ACS studies, which were pretty strong, and we had access to the master file of the AMA, which allowed us really to survey physicians all over the country, survey various specialties and subspecialties, and to compare it to the probability-based sample of the U.S. population. So we sent out invitations to roughly 90,000 U.S. physicians, roughly 27,000 opened the email. We sent out 3 separate emails, and about 7,300 completed the survey. Now, as you probably know, JAMA doesn't publish a survey in which there's less than 50% compliance. However, as you'll see, the power in our sample size is such that even if we had 50% response, our associations would still hold. And we compared it to the 3,400 non-physicians. We knew that the 22-item ASLOC burnout inventory and the 3-item inventory were equally diagnostic, but we wanted to look at the 2-item inventory. So we did both the 2-item and the 22-item. We used a 2-item prime MD assessment for depression, which is well validated, and a single SI question. Our single SI question was, have you had serious thoughts of ending your life in the past 12 months? And we used Likert scales to look at satisfaction, professional and personal, and work-life balance. So this was a sample. We, in situations in which there was a smaller subspecialty representation, we would weight it so we had an equal representation from them. But basically, this was a replication of the ACS study. Instead of 40% burnout, it was 38% burnout. And again, the highest item being emotional and personal exhaustion. I just misstated something. 38% was high emotional and physical exhaustion. And in aggregate, 46% of U.S. physicians from all the specialties and all the subspecialties met diagnostic criteria for burnout. And again, we concentrated on this because this is an easily treatable, reversible condition. 38% of American physicians screened positive for depression, and 6% had had suicidal ideation in the preceding 12 months. So we have a very sick physician population. And looking at the various specialties, this is percent reporting burnout, and the lowest percent, this isn't much of a surprise, preventive medicine, occupational medicine, environmental medicine, dermatology, pediatrics. At the top was emergency medicine and general internal medicine. General surgery, surprisingly, this is reporting burnout, was a little less, 40% versus 43% that I mentioned. And here we were, kind of about halfway between the mean and the lowest percentage. Slightly above neurosurgeons, which I find difficult to believe, but whatever.
The neurosurgeons might have been too busy to respond to people.
Yeah, could be. And, you know, that has been a criticism of these studies is that, well, presumably the people that are sickest aren't going to respond. They're not going to take the time to do a survey. Well, if that's true, then actually the results are going to be much more compelling. So, and then looking at those that were satisfied that work left enough time for personal or family life, the ones who said that work left enough time were the ones that were at the very bottom. So it was an interesting replication of results: dermatology, pediatrics, radiology, ophthalmology, pathology. And here we are. So relative to our other specialty cohorts, we're doing pretty well. And the folks that were had the least amount of time left over to deal with personal family life were general surgeons. When I was head of trauma surgery here, I would fly back from giving a talk, turn on my pager. I would be paged. I would go to the OR. I would operate all night long, and then go home the next day. And that was a pretty good example of everything you don't want to do when it comes to work-life balance. Well, what about when we compare it to the probability-based sample of the U.S. population? So the average physician works about 53 hours, significantly more than their professional counterparts. PC stands for professional counterparts. Burnout has a statistically significant, much higher rate of burnout. About the same incidence of depression when using the two-item Prime MD. Roughly the same incidence of suicidal ideation. And in terms of work schedule, leaving enough time to have a healthy and meaningful personal life, 40% of physicians disagree, and about 1 out of 4 professional counterparts. We looked at suicidal ideation in 2011, and this was really, I think, very provocative. There have been some excellent studies on physician suicide, but we really wanted to look at the relationship of suicidal ideation to self-care. And as I mentioned previously, about 6% of surgeons had thoughts of suicide last 12 months. 78% had symptoms of depression with a 2-item scale. Only a fourth of them sought psychiatric help. 60% of them said they did not seek psychiatric help because they were concerned about this information becoming available for example, to the Medical Quality Assurance Commission. Under Washington state law, your identity cannot be made known to MQAC unless you're non-compliant with recommendations for treatment. Only 22% had used an antidepressant, and 26% self-prescribed or had prescribed by a colleague, and by a colleague, I mean a colleague surgeon. So I guess the old days of being a cowboy are still very much present. And it's been a pleasure for me to share this at the ACS. But it's been fantastic that the leadership has been so supportive and said, let's find out what's going on with the fellows in the college. And then 2 years ago, we started looking at, actually 3 years ago, looking at substance use disorders in American surgeons. Now, this is what we know about the general population. Even though psychiatric literature says the incidence of alcohol abuse and dependence, substance abuse and dependence, is about 10 to 15%. The literature really shows that it's more like about 10% of the U.S. population, lower than I think we as psychiatrists have come to believe, and that males are twice as likely as females to suffer from alcohol dependence or abuse, and that otherwise it's consistent across demographic groups. But what do we really know about substance use disorders in physicians? Not much, at least prior to this. Most of the observations that say physicians have a higher rate of substance use disorders are extrapolations from a myriad of different databases. And this 10 to 15% that's been out there that is quoted in chapter after chapter after chapter, really, when you follow it all the way back, someone made that statement and everyone's been quoting it ever since. We do know that because of our prescribing ability for high-potency opioids and sedative hypnotics and anxiolytics, that we as physicians are much more likely to get addicted to prescription drugs. Well, the methodology was very similar to what I've mentioned with the AMA. We had complete access to the email database. It had already been established. If you submitted your email address, you're willing to be contacted. We had 3 letters from the director and the president of the American College of Surgeons strongly encouraging surgeons to respond to the survey. And we did a survey in 2008, 2010, and 2012. Very similar to what we've done with the AMA. We use the AUDIT-C, which is the first 3 questions of the World Health Organization audit. And it has been demonstrated repeatedly. This is just as accurate as doing the whole thing. And Dan Kiblahan at the VA has done a number of studies using the AUDIT-C, and so it's well vetted and validated in both family practice and with veterans. So here are the three questions. One has to do with how much or how often had you had a drink in the past year? When you drink alcohol, how many drinks do you typically drink? And how often do you have 6 or more drinks on an occasion in the past year? Things have totally changed about this. When I was a surgeon here, we used to have liver rounds in old Harborview Hall on Friday afternoon. And the limit was if you were on call, you couldn't have more than 2 beers. Since then, there was a study about 4 months ago that shows that surgeons drink the night before a laparoscopic cholecystectomy, because they're not on call, so they feel comfortable doing it, will have a measurable decrement in doing a virtual lap chole the next day. So the pendulum, I should say, has swung substantially. Dan Kiblahan and several of the other people used a score of 4 for men and 3 for women as indicating unhealthy alcohol use. That means alcohol use that's had at least one consequence, which is the same as alcohol abuse. We wanted to have better specificity. We're willing to give up some sensitivity to have that. And so we picked an extra higher point, 5 for men and 4 for women. And this is what we found. 30% of surgeons completed the survey, and of those that completed the survey, 15.5% had an audit score consistent with abuse or dependence. 15.5%. 1 out of 7. And the point prevalence for male surgeons was 13.9, and for female surgeons was 25.6. So twice as common, again, as is with the suicides. Julie Fleischlag, who's the chair of surgery, she just moved and became the dean someplace in California, teased out a lot of this. And when you look at work-life balance issues among female surgeons versus male surgeons, there's tremendous conflict over work versus life. And the Likert scales are much lower. And she believes that's probably the reason it doesn't show direction of effect. It's just an association. Intuitively, that makes sense. I want to share some of the actual data. So looking at alcohol abuse or dependence, this is where the AUDIT-C 2, 5 for men, 4 for women on the AUDIT-C versus no symptoms. The incidence of burnout was highly, statistically significantly higher, 35% versus 25. The incidence of depression, 50% versus 37. The incidence of suicidal ideation went up to 8% for those that had alcohol abuse or dependence, and all of the Likert scales were much lower with respect to mean overall quality of life, mental and physical quality of life. Now again, this isn't direction of effect. We don't know if burnout causes substance abuse or dependence or vice versa, but the correlations are very high, and if we had a 50% response, when you have p-values of less than 0.0001, there's enough power there that even if we had a 50% response, this would still hold. Really clever biostatisticians can figure that out and then tell us. When we looked at the multivariate analysis in which we controlled for the other variables, and a normal odds ratio was 1. So being male was protective. It was worse if you were partnered or married versus single. Better having children. The burnout presented at a 1.259 relationship with alcohol abuse or dependence, as did depression, as did a major medical error in the last 3 months. And I need to define that. We wanted to have a fairly generous definition. So we excluded whether or not actual patient damage had happened. We did kind of the heart check. In the past 3 months, have you made an error in judgment that may have adversely affected a patient? That was the question. And we saw that physicians that had burnout had a much higher response in terms of major medical errors. Now, obviously, there's a lot more work to be done to tease out a lot of this. But as the data sets providing a foundation for a strong association, it's very hard to argue against this work. So we concluded that surgeons suffer from alcohol abuse or dependence at a rate higher than the general population, that there's a strong association between alcohol abuse or dependence in surgeons and burnout, depression, suicidal ideation, medical errors, personal and professional quality of life. We had questions like, are you satisfied with the intimacy in your personal relationship? We really drilled down a lot in terms of personal and professional quality of life issues. And I just want to emphasize that one of the nice things about doing this work is the opportunity to talk about what the results are when someone's actually diagnosed with abuse or dependence. So in the state of Washington, and we publish this in the archives, Prognosis for Recovery of Surgeons from Chemical Dependency, 81% of surgeons diagnosed with substance dependence, not abuse, substance dependence, who had treatment and were monitored for 5 years under a contract, did not relapse under those 5 years. Monitored chemically, professionally, behaviorally, did not relapse over 5 years. And we all know this, like the inverse from the population, where about 80% of people relapse. So it's really quite remarkable. It's the best results there have been. So point being, and this is one of our selling points to the College Board of Governors, is that not only is it important to diagnose this, but that in fact the recovery is so good that you end up with a person who is safer than their unknown counterparts. In studies that have been done of medical malpractice claims in Colorado, physicians monitored by the physician health program there, doctors that are monitored end up having lower malpractice claims for periods up to 20 years from the time that they're monitored. So they're safer than their unknown counterparts. The sensitivity specificity argument always comes up. You know, why did we choose 5 for men and 4 for women? And again, you know, we don't want to have false positives, obviously. So we sacrifice some sensitivity for specificity, but not much. So I want you to take a wellness test with me. So as I go through these questions, you can just decide whether or not your response is positive. And at the end, I'll tell you whether or not you're healthy. I find meaning in my work. I really look forward to going to work. I like my partners. I really like the patients that I see. It's fun, it's convivial, it's collegial. I really enjoy going to work. I find meaning. I protect time away from work with my spouse, family, and friends. I take every Saturday off. I still work around 62 to 65 hours a week, but I take every Saturday off, no matter what. Maybe that's not a very good example. I focus on what is important to me in my life. I believe spirituality is the distance between two human beings. We concentrate on similarities, we come together, and the me becomes a we. What's important in my life are my relationships with other human beings. And I'm only about as happy as my worst relationship with another human being. So I need to make it right, make an amendment. I try to take a positive outlook on things. I wake up in the morning and decide that I'm going to be happy. And I can actually stay happy if I leave other people alone. If I just leave them alone. If I do something really nice for the people I love today, I leave them alone. I don't tell my son, you know, a really brilliant way to solve his problems. I say, gee, that must be really hard. I'm sorry that's happening to you. I'm sure you'll come up with a solution. I take vacations. I participate in recreation, hobbies, or exercise. I talk with family, significant other friends about how I'm feeling, with the emphasis on feeling. That's the down here stuff. We've got to move it from here down to here. I've developed an approach philosophy to dealing with patient suffering and death. Most of us have not. And we have huge existential angst about our powerlessness when a patient's going to die. Huge. I incorporate a life philosophy stressing balance in my personal and professional life. I look forward to retirement. So I have a friend who did a seminar for the Washington State Hospital Association on retirement, and he invited in a number of people that had retired to do a roundtable so they could talk about how happy they were in retirement. This is a true story, but he didn't really ask them. So as the seminar started, he introduced these guys and said each of them going to comment about how happy they are to be in retirement. 8 of the 10 said they were sorry they were in retirement. I discuss stressful aspects of work with colleagues. I nurture the religious, spiritual aspects of myself. I'm involved in non-patient activities. Our studies have all shown if your professional life involves teaching, research, you're much healthier than just taking care of patients. Narrative medicine is telling stories about our patients, writing a short story about the patient, not as the person, whose head of pancreas we took out, but in terms of what we learned from our patient and what was important to them. I engage in reflective writing or other journaling techniques. I've been journaling for 21 years. I write a paragraph or two before I go to bed. I sleep better because whatever it was is on a piece of paper in the nightstand, not in my head. And then this was the ringer we put in. I have regular meetings with psychologists and psychiatrists to discuss stress. If you answered 6 of these positive, what our experience has been is that you're probably in pretty reasonable shape. Just 6 out of 16. A couple of other things before we take some questions. So David Marks wrote a book called Whack-A-Mole. Now, for those of you that are younger, Whack-A-Mole is an old arcade game where you take a mallet and you whack the mole as it pops its head up. And Mark said that that's how a lot of residency training is. It's kind of whack-a-mole. Calling somebody out, making them feel bad. And he suggested the just culture paradigm as a different option. And the just culture paradigm is what in many institutions, Virginia Mason is all over that, but it comes from the airline industry, and that is when a mistake is made, it's never made by an individual. It is made by all of the individuals. And that we all share in that mistake, and therefore we all work to prevent the mistake, and we all work to learn from the mistake. That wasn't the way it was when I did a surgical residency. It was blaming and shaming. And you would get so PO'd that one would go ahead and learn that topic, stay up for 5 or 6 hours learning about it. So, but there's still a lot of residencies that do that. Power versus powerlessness. I would ask you, so in waking up and deciding to leave people alone, what I also had was the revelation of how many times my 2 kids have ever come to me and said, Dad, when you said that to me a long time ago, well, I did it and my life is better. As best I know, my children have never followed any suggestion I made. They have learned from their own mistakes. So do I have power over them? No, I'm really powerless over them. Connection versus disconnection. Self-knowledge versus self-awareness. Self-awareness is seeing ourselves as others see us, not as we perceive ourselves. And most importantly, giving ourselves permission to be sick and expecting the same quality of medical care that we provide to others. And Lee Lipsenthal wrote extensively and beautifully about this. He died 2 years ago. And wrote a manuscript right before he died, and these are several things from that. Our perception creates the world we live in. Developing gratitude, healthy boundaries, releasing the need for control are the best weapons against burnout. Developing gratitude, waking up in the morning and being in a negative emotional or affective state, write down 5 things you're grateful for. It'll change. You'll feel better. Taking that action, we think and feel differently. Classic CBT.
Yeah, too simple.
Too simple, but it works. It works amazingly well. And realizing that our state of well-being does affect our patients. You know, it isn't about the slip of the scalpel and transection of the common bile duct. It is a lot about how we leave the patient's feeling when we leave that interaction with them. Photograph? Did you get it? And Viktor Frankl said, everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances. It isn't what's going on that dictates whether or not we're okay with it. What's going on out there is very dependent on how we approach it, truly how we approach it, and we can actually pick and choose to be happy. So I'm going to go ahead and stop there and see if there's any questions from the VA or UW or from this audience. And the other guys are going to write me questions in the box. Hello out there. If you're out there, VA, UWMC, we'd love to have some questions. Any questions from the audience? Richard.
It's a wonderful presentation and important message. I've had the pleasure of working with Carlos Green for many years on his work with the non-professionals, and I'm not a little bit surprised that he is advocating and supporting this work. It's a wonderful outcome. I had a question. You made a couple of allusions to the statistical issues around rather small response rate in the first large study. And although I do understand that translation. I wondered if your second study actually didn't provide an additional opportunity to validate the first. You showed us the relationship between the substance use and the burnout depression, but I wondered if just a straightforward burnout depression, if you saw in that sample, which was 30-some% response rate, similar or equivalent incidence findings compared to the first.
Yeah, we just submitted that abstract to the American Journal on Addictions, the AAAP journal. It does. It replicates it. It's amazing how it replicates it. The numbers are very, very similar. Thank you for the comment, too, about Carlos. I was flying back from Chicago a couple of weeks ago, and Carlos was in first class, and I was in the back. And I told the stewardess, I said, you know, there's a very famous surgeon sitting up in first class. By the time he got off, he was waiting for me when he got off the plane. They were all asking him if he was a TV or a film personality in first class because they thought if you're famous, it must be because you're an actor. So it was fun. When you see him, you'll have to remind him. He got a kick out of that. Yes.
Did I understand correctly that the measure of errors
Yes, the question for the VA and UWMC is, was the measurement of medical errors by self-report? And the answer is yes, it was. The logistics of the study really didn't lend itself to that because we didn't really know who the patients were. Thank you for asking that.
Thank you. The prevalence of alcohol user dependence among surgeons was 26% for women and half that for men. So men were slightly over the general population, but women were 4 times. But usually men have twice the prevalence of women, and in this case, women had twice. What's the story there?
Well,
that didn't even consider drugs, right?
That did not consider drugs. So the question that was asked was this incidence in female surgeons being twice as high as male surgeons and being multiple times higher than the counterparts in the general population. Basically, what is that about? And again, Julie Fleischlag is trying to tease this out, but the association appears to be the higher incidence of substance abuse or alcohol abuse or dependence with a much lower quality of life issue when it comes to do I have enough time for my work to be able to address and take care of my family and relationships. So female surgeons in general appear to be much more effective by, possibly by maintaining multiple roles at one time. Does that answer the question?
Despite drinking.
Despite drinking more.
I also wondered whether there might have been a difference in the rate of completion of surveys and maybe even the honesty in surveys and in women versus men in the different cultures.
You know, I don't think, I'm not intuitively, I think that's very, very true. And that there was probably more self-disclosure by female physicians than male physicians. It's really interesting, and looking back of, you know, doing a survey of physicians, is that even a reasonable thing to do? The data has really shown that people are pretty forthcoming when confidentiality is absolutely assured. As best I know, no one has looked at that, but intuitively that makes a lot of sense. Dick?
And has anybody looked at, number one, the food chain of prescribers, physicians on top, and then going down to the PAs and A&Ps, all this, versus the power structure, which is physicians, and then as you go farther down, you have more conflicts from below and above versus being always on top. Do you know anybody is doing any of that?
That's a really good question, and I don't know. I'm not aware of any data in that regard. The data looking at academicians generates very similar results. Just, for example, the Hopkins faculty, which has been fairly extensively studied, and the Mayo Clinic faculty has been fairly carefully studied. And there is no safety net within academics with respect to how high you are in the hierarchy, but whether or not that relationship and those multiple relationships and different degrees of power, I don't know the answer. Really looked at that.
There's a question.
It seems like acceptance and availability of part-time MD positions may help the situation. Your thoughts? That's a really good question. I am not aware of whether or not. Well, let me change. I was just about to say something which is actually quite inaccurate. When we looked at hours worked and nights on call, you remember the odds ratio was like 0.9 something. So really no difference one way or the other in terms of whether or not that was more predictive. However, when you got beyond the 60 hours a week, it was highly predictive of burnout. So hours worked, nights on call, and when one was on call more often than 2 times a week, it was highly predictive. So excessive work certainly is a predictor. Increasingly, we're seeing people taking part-time positions, and I think that's really important, and it's a great thing to see, kind of an evolution of, I don't have to do the 40-hour-a-week job. But we really don't know, looking specifically at part-time physicians versus full-time physicians, whether or not that's protective or predictive.
I wonder if you could give us a long-term historical perspective. That is, how have suicide rates for physicians and surgeons changed over the last 100 years? And I know that has to be corrected for broader historical societal trends, but look over several decades.
Yeah, that's a really great question, and Erica Frank has been looking at that quite a bit. For the last 30 years, the rates have gone up each decade. The incidence of completed suicides has gone up each decade. It's very difficult to get an accurate estimation of what it was, say, before 1970. It's really very difficult. Most of the data comes from necropsy studies or medical examiners' offices, but there's a lot of missed cases. But in the studies that were much more scientific and much more thorough, there's no question that the incidence of suicide has increased. The incidence of suicide among dentists has remained stable. And the question always is how much of this is an accidental overdose. For example, among anesthesiologists, is this actually them ending their life deliberately by taking a lot of fentanyl, or were they trying to titrate the fentanyl drip to get the ultimate high and still be conscious? And the supposition is a lot of those deaths are accidental and not deliberate. But overall, yes, physicians are ending their life more and more all the time.
I'm curious if there's any role for the residency training program or medical school, and if that is protected, but then if it's a more fewer hours or more, any sort of intervention done then that is protected for burnout later on.
Yeah, recently, so Lottie Durby and Ann Ecker at the U, a number of people have been looking at medical students in terms of health and well-being. The incidence of burnout during medical school is 50%. It's even higher, 50% meet diagnostic criteria at some point. It looks like the University of California, San Diego started this proactive mental health support system for medical students about 12, 15 years ago. And the early data from that suggests that actually being proactive and processing conflicts and feelings as they evolve in the stress of going through medical school is protective. So an early introduction as to a therapeutic approach as to how to deal with things that bother us as we're going through our training appears to be protective.
The gender differences in suicide and substance use are really troubling. I'm wondering if you have yet any perspective on the effects of the 8-hour work week, which has allowed more women to choose these traditionally more male disciplines to enter, I think because it is more flexible. Are we seeing or anticipating some improvement in these things?
I think we're definitely anticipating some improvement. So far, there's only been really one study that's looked at the consequences, not the consequences, the benefits of the 80-hour work week, and it's a very positive signal. But a lot more extensive work needs to be done. Yes.
Sort of related to that, with the gender differences, is there any sort of association, I don't know if it's hard to measure, but women in fields that are typically more male-dominated or comfortable with their work as separate from work-life balance?
Yeah, there's been fairly extensive studies done of female surgeons, and with respect to how happy or unhappy they have been in their training and in their career. And the results were so compelling that the ACS created a number of different work groups to look at how to provide a kind of support, for example, for a female transplant surgeon. Really an intense subspecialty. So, and I can tell you unequivocally, sitting on the committee with a number of female surgeons, that's a really important topic that comes up all the time. One last question. Enrique, what kind of health food bars should I be eating now? Spirulina?
In terms of changes that could accomplish the health with burnout, do you think it's more the individual or
Yeah, absolutely, and this is kind of a compelling example. Is actually emphasizing as a part of Grand Round's health and well-being. But anyway, it's both an individual and a system thing. The desensitization towards having it and the willingness to come forward and ask for help is very much a systems issue. The self-assessment stuff, the well-being index, the 7-item well-being index that we have online at the Mayo Clinic is very helpful because it gives immediate feedback and says you're suffering from burnout and you're suffering from a minor depressive episode, and these are the resources that are available. And we're doing a follow-up at 3 months in terms of whether or not people have actually taken the action that's recommended from the well-being index. And that's part of the AMA study. Well, thank you very much for letting me come back.